So the evolution is something that we will discuss eventually. The first thing is, if there are so many points that just came up, it doesn't offer a significant advantage over a good cataract or a reasonably good cataract surgeon over phaco, then why do we have it at all? We have it for different people, might have different reasons, but I had, when I purchased the machine around 7 years back, I did it because I wanted to have my share of the educated technocrats fun. That's all I want. I love working with machines. I love understanding them. And that's the reason why I had it in place at the first place. So this is how the laser concept evolved in the world. The first laser was built by, we all know this, Theodor Maiman, using a ruby crystal medium. That was way back in 1960. And the first clinical ophthalmic use came in 63. The YAG actually was a landmark discovery and that invention, sorry, and that's from where it took a huge leap. That came in 71. Excimer was developed by Trockel. Femto laser was approved by the US FDA as late as 2010. So that's actually a significant starting point of the laser technology coming into the aid of cataract surgery in particular. But whatever we do, we cannot forget this gentleman called Mr. Theodor Maiman, who actually gave us the gift of this concept way back. These are certain terms that are applied to lasers. One is frequency. Frequency is the number of laser shots fired in 1 second. It determines the speed of laser. The LensX, for example, operates within 50 to 150 kHz. The Catalyst always operates under 100 kHz. So technically speaking, the Catalyst is a faster machine than the LensX. That's the reason why it performs the capsulotomy way faster than the LensX does. I'm not talking about the overall surgical or procedural time, but the capsulotomy is way faster. Wavelength, as we know, with any light, it's the distance between two successive crests or troughs in a sinusoidal wave. This determines the type of laser, and femto is an infrared laser operating in the 1030 nanometer range. Pulse width is the laser exposure time for the targeted tissue. It's either 10 to the power minus 9 for a nano, 10 to the power minus 15 is femto, and 10 to the power minus 12 is pico. Out of the platforms that we have in the industry, the LensR is actually a picosecond laser. It's not a femtosecond laser, strictly speaking, but the other platforms are all femtosecond. Energy, the amount of energy required to create an effective action, which is for the LensX around 3 to 15, and most of the platforms operate within that energy range of 3 to 15 microjoules. This is where the LensX laser and all the lasers virtually stand, 1030 nanometers. We know that the visible spectrum lies within 400 to 700. So this lies on the infrared segment, and these are the invisible segments of light. Let's look at the science of the lasers, femtosecond lasers. As we discussed, they have a wavelength of 1030. It works on the principle of photo disruption. Now, laser has got three basic properties. One is thermal interaction, which is heating, basically coagulation, carbonization, or vaporization, and it produces huge collateral damage to the surrounding tissues. So that's something we cannot use for cataract surgery. The second is photoablation, which is basically molecule bond breaking. So this is what we do in refractive procedures, predictable tissue removal and low influence on the surrounding tissue. The least amount of effect on the surrounding tissue comes from this photo disruption principle, which is basically ionization of atoms, formation of a shock wave, and that's what disrupts the tissue and causes a cleavage in the dense tissues such as the nucleus, and it has very low influence for surrounding tissue. This is the laser engine. It has one of the components is the oscillator, which produces the desired laser pulse. The next component is a stretcher. It stretches the wave, amplifies and compresses into a narrow beam. That's the second component. Finally, there comes the energy section, which is responsible for delivery of the energy through the desired pathway. A thermal shield is there, obviously, because it produces a lot of heat energy, which can direct the sensitive components of the machine itself. So there is a thermal shield. And this is the crystal that is used. It's called the terbium doped potassium yttrium tungstate. Every time it has to be read from the slide. You cannot remember this is a real tongue twister. Now we go to the comparative account of the platforms. The first comparison is the reason why Dr. Sri Ganesh has it in the same OT. The area the machine occupies is the least with the Zymer Z8. It's massive with both Catalyst and LensX. And LensX perhaps is a bigger machine than even the Catalyst is. But the Z8 is actually the smallest of them. There's a reason why you can keep it inside the OT. So the footprint is actually not the carbon footprint. The footprint of the machine is the least with the Zymer Z8. But this is not what we are discussing. Let's talk about the OCT first. How is the OCT taken? The LensX, what it does is it has a real-time HD OCT imagery as you go down to dock the machine. Okay. For the capsule, what it does is it takes a ribbon-shaped cut of the whole capsule at the plane where the capsulotomy is performed, which is a little below the most convex region, and then it stretches it out. So even if while docking the eye has moved a little, this is how the shape comes in, an S or sinusoidal shape. Then you can move your cursors to adjust to the highest and the lowest point. So even if there is a subluxation of kind or there is a tilt of the head, it kind of adjusts for that. And you can see that in the real-time live OCT imagery. So that's what the LensX does. The Catalyst uses multiple line scans across the eye and then combines them to process to locate the angle corresponding to the relative maximal tilt. So it also has a tilt adjustment. And then there are sagittal and axial scans as well. The sagittal scans and the axial scans, which define the capsular boundary. But it does not give you a line. This is how the imagery comes in, and you have to adjust the capsulotomy according to that. The details about the Zymer Z8's OCT is not available to me in any case, but what I have understood is it does not have a video monitor which will show you the real-time docking, but it does show close to what the Catalyst imagery shows, and then you can set the boundaries of where you want to have the capsulotomy. The Catalyst and the LensX have, the Catalyst has the laser gantry which is fixed. So if you want to move the head up or down, it has to be done by the movable bed. The LensX laser gantry moves. So it has a variable numerical aperture. You can dock the patient and then the laser head focuses on one tissue like the capsule, withdraws and focuses on the cornea, goes deep and focuses on the nucleus, which is something the Catalyst cannot do because it doesn't have a movable laser gantry. The Z8 has a variable numerical aperture, but it's there in the handpiece. It's not on the laser gantry. It's there in the handpiece. So the numerical aperture moves, but the movement or the threshold of movement is slightly less than what the LensX can do because obviously the whole machine, the whole gantry is moving. It's actually more.
You can go down up to the poster capsule also.
Here also you can go down to the poster capsule.
Yeah, so it's quite a bit, the range.
No, but
you can do poster capsulotomy.
I don't know, sir, when I read the patent papers, this is what it shows. The laser spot in case of a LensX is actually optimized for the capsule. However, because of the movable gantry, the focus can be on the capsule, can be on the cornea, and can be on the nucleus. This is where the Catalyst stands. It focuses on the capsule. It is not optimized, so it goes up, under delivers for the cornea, so the corneal incisions are not that good, and the nucleus, it goes down to produce deeper cuts. With the Z8, the focus is actually on the cornea, so the corneal incisions are the best with the Z8 amongst these three platforms. Although the laser optimization, the focus is because of the limitation in the movement, the focus is not much, the optimization is very good. So the Z8 also produces excellent capsulotomies and excellent nucleotomies because the optimization is very good. What's even more interesting to note is the LensX and Catalyst have spot size like these, and the tissue bridge between them is quite a bit. So you really have to mechanically open them, the corneal incisions in particular. But the Z8 has laser spots very small, and the bridges are absolutely non-existent, almost non-existent. So they open in a jiffy. But the disadvantage with that is, once you have docked and the tissue bridges are not there, the corneal incision is almost free-flowing, it establishes a communicating channel, which is why, I don't know whether Sir has it for that purpose, but which is why it is a good idea to keep the Z8 in a sterile environment inside the OT, because you can have communications before even the patient is transferred to the OT table, the phaco table, right? So Nucleotomy patterns, all of them offer us these choices. You can chop, you can cylinder, you can frag, you can honeycomb. So all of them have, we just have to choose which nucleus requires what for the optimal balance between the energy used for the purpose and the result the outcome that we wish on the other side. So that's all for the platforms. Thank you so much for the patient listening. Yes, sir.
The difference in the capsulotomy is also there, because if you look at the Z8 capsulotomies, they've done microscopic studies also, where you can see that the edge is quite pristine because of the overlapping, very small overlapping spots.
Yes.
You don't have that postage stamp kind of a edge which you get with the other platforms. Then the chance of having bridges and runoff is more. With the Z8, it's almost like doing it with a needle.
And it's actually if your tissue is like this, both the Z8 and Lensex, what they do is they run it repeatedly so that the tissue bridge is minimal. The catalyst actually lags behind in that because it's a fast machine, so the tissue bridge is likely to be less, and you could have microtags. It's not visible under the microscope, of course, only on electron microscope.
Microtags in the catalyst is very common, very common. Almost, I think it is a 50% cases there is a microtag.
In fact, I had a catalyst. We got the first catalyst in India, 2012, and I gave it up because there were no improvements. There was nothing that the company had done after J&J took it over. Alcon has bought over Lensar,
yeah.
so Lensar
That was big news, actually. That was big news.
Now, since the Rexis is a very important outcome of this usage of flags, I think we need to work on, discuss a little more on this, like how to get the best Rexis without these micro tags or peripheral runoffs. Is it the delta that you have to adjust very meticulously in each case that really ensures a perfect Rexis, or is it some kind of a variation in the energy delivery, or is it the type of capsule that kind of have a different reactions to it?
See, it is a pattern also. With overlapping spots, you get less amount of tags. The other thing is, if there's a shift in the plane of the anterior capsule, then you can have
The
tags.
delta that if you adjust.
Yeah, that delta is normally at 400 microns. But you can even increase it to 1000 microns. We did a study also in intumescent cataracts.
Yeah.
Even if you increase it to 1000 microns, the tags are less, but still you get tags. Because what happens is, when the
Milky
lens is under
fluid
pressure, and once you make, it starts making the cut, the plane shifts, because the
Fluid
the lens
escapes.
material comes up, and then you have tags. So that's why for a intumescent cataract, always stain with trypan blue and use a forceps, look at the edge and then peel off the rexes. Otherwise, if you think, you assume it's free floating and you go in.
Not only the shift, it's even that white cortex, liquefied cortex, which actually makes the whole thing muddy. And
it can block the laser.
It can block the laser.
That is, liquefied, but in intumescent, if it's like a Morgagnian or something like that, then the fluid comes out, then it becomes murky, then the laser will not penetrate.
And as Dr. Ravi Kumar Reddy said, they were the cases who will agree for lenses more than the routine ones.
Particularly the margin, that the delta you have for the inferior laser should be more, because the capsule tends to fall back the moment the fluid starts leaking. We'll discuss loads of that, but for the moment we come to the only what would I say, the holy grail of flags, the cases where the flags is of absolute paramount use should you have the machine with you, the posterior polar